1 second, I gotta put it on YouTube
Live,
because a lot
live
of people watch
stream.
this. We don't even know.
Okay.
Hold on.
Yeah, everyone's pretty excited for this.
Just 1 second. Okay, Michael, are you there yet? It's not. Okay, Michael, you all set?
1 second.
Okay.
Okay.
How many miles you do?
I think about 15. Mountain though, so it's a
Up
lot.
and down, huh?
Yeah, a lot more challenging that way. Okay, I'm ready anytime.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach, Dr. Bennett of Neurosurgical TV. We have the extreme honor of having Michael back for the second time in 2 weeks. We're really lucky. But let me introduce the representative from Neurosurgical TV, Marwan Jahar. He's a fifth-year medical student from Georgia, the country of Georgia. Welcome, Marwan.
Thank you, Dr. Lawton. Yeah, thank you for having me and for this opportunity. I'm really glad to be here. I'm a student in University of Georgia, Tbilisi, and I would like to welcome Abdurrahman Alitor, who is the founder and president of Global Neurosurgical Students Council, for organizing this webinar and this event.
Okay. Good evening, everyone. My name is Abdurrahman Al Itir, a global president of the Global Neurosurgical Students Council, supported by Robert Spitzer. It's my great honor to welcome of you to the Masterclass in Vision, Precision, and and lifelong uh, dedication to excellence in neurosurgery. It's my great honor uh, to welcome of the greatest of 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 the greatest in neurosurgeons from the world, uh, ha- pioneer whose work has shaped the very foundation of cerebrovascular and skull base and skull base surgery. Dr. Michael D- Dr. Michael Lawton, chairman of the Harrow, chairman of Harrow Neurological Institute, stands as symbol of surgical mastery, innovation, and dedication to advancing the art of neurosurgery worldwide. Uh, Everyone, please join in welcome Dr. Michael Lawton.
Okay, well, thank you for that
Okay.
introduction. And it's great to be here. Well, I gather that this is a collection of mostly medical students. And so I thought what I would do is basically give you my rundown in 25 minutes of kind of what the future of neurosurgery looks like based upon where we stand at present. So let me just jump in. This was a lecture that I gave in honor of Ralph Dacey, who, like many academic neurosurgeons, is what I call a triple threat, meaning that he's both a consummate neurosurgeon with great technique, a research scientist who does basic laboratory studies, and thirdly, an educator and author. So in line with who he is, I wanted to address the state of the art of cerebrovascular neurosurgery from these three angles, from that of the clinical side, the research side, and then the educational side. So this will be kind of a state of the art, and hopefully will identify for your generation imperatives for the future, which is really what you all need to think about in making your career choices and carrying the torch into the next generation. This is my career on a slide, 28 years since I finished training, and a very sharp focus on vascular cases, as you can see. But what's striking is how the trends are not in my favor. You can see that I started in 1997, and it was a steady climb, steady growth in my case volume of open aneurysms. And then as endovascular therapies evolved and became competitive and then overtook open surgery, you can see that the volume has diminished. Not a happy state, and it reflects the fact, well, all of these facts about endovascular surgery and the endovascular era. You know, there's the easy access, the rapid revolution or evolution of devices, the strong market forces from industry. Patients prefer what's minimally invasive. And frankly, it's easier to learn this than it is to do to learn how to split fissures and take down clinoids and manage ruptured aneurysms face to face. So for all those reasons, we've seen this rise of endovascular case volume to the detriment of open surgery. These open surgical cases are now reserved for aneurysms that are less favorable for coiling or flow diversion. Stroke centers work against us. They decentralize aneurysm care. They move experts out into the hinterlands so that they're on the front line for stroke care. And that tends to diminish the amount of referrals into the tertiary centers. So we see decreasing volume. Globally, there's a decrease in expertise, and there are fewer jobs that reflect that trend. With that, ultimately, there's going to be impacts on patient outcomes. As we lose expertise, lose numbers of surgeons, lose manpower, we're going to potentially compromise outcome. So I did get my endovascular training, and you can see here, it was a 3-year effort. I enfolded it as an attending, a faculty at University of California. And Van Halbach, one of the pioneers in endovascular surgery, was my director. So I did go down this road. But I think for me, it was more like the Michael Jordan story than the Howard Rena story. I found that I was better and more passionate about the open surgery than I was about the endovascular. Just as Michael Jordan tried to become a great baseball player, ultimately he returned. And I think that was my story. But I think for the future and for the young generation, the Howard Rena example is the example of embracing the hybrid model, learning to do both, and developing that expertise so that you're positioned for the future. One of the things that's important is to maintain a robust training program for open vascular neurosurgeons. And this is a slide showing my graduates from my fellowship program and also from my residency program at Barrow. The more you engage the future generation and you train good talent, I think the safer the future becomes. And committing to a robust vascular fellowship with plenty of cases and a lot of good training is really important for the future. I think you need to subspecialize. So this is the Patagonian range, the Fitzroy range, but the point is over here, which is to stay in your lane. You have to pick your area of expertise. You have to stay within that lane. And if you're in a department where everybody adopts this principle, then you get cases that other partners of yours get because they refer to you, and vice versa. When you get gliomas or spine cases, you refer to them. So this subspecialization format within a robust department is a way to have a robust practice. Now, referrals are the bread and butter of building the future. You need doctors out there in the communities who see these patients on the front line to send cases to you. And so I think developing those networks is essential. I think one of the ways you do that is through your expertise, establishing yourself as the person who's the expert in a particular area. This slide is meant to show how, I spent the last few years really writing 7 cavernomas and publishing papers on cavernous malformations. And that has generated a lot of referrals that weren't there before I started this. I can definitely see the upward trend in referrals because of all of the work done to advance the science. It would be great if we could quantify who's good at aneurysm surgery and who's not, just as we quantify who's good at the quarterback position in American football. There are ways to grade or quantify that. And unfortunately, we don't do that for neurosurgeons. Transplant surgeons have made an effort. This is the Scientific Registry of Transplant Recipients, and they have reams of data on surgeon mortality, surgeon morbidity, times to transplantation, et cetera, et cetera. And so this is an effort to get data that quantifies performance. And honestly, this is really something that would advance our specialty in driving aneurysms to the right places. Social media is huge. I am present on Instagram, Twitter, or X, and Facebook, and the engagement here is dramatic. You can reach a lot of people, not just referring doctors, but also patients who increasingly these days are in control of where they go and who they see. And so this has become a really important way to engage patients and connect with your clients. Being in a health system, at least in this country, is important. Health systems are networks of hospitals, and patients that come into that network can be funneled to centers of excellence. And so if you're lucky enough to be in a system that has a network such as that, this can be a way for you to generate referrals and business. Other microneurosurgery is important to develop. I show this graph to show that how, when I came to Phoenix 8 years ago, tumor surgery was really not so much a part of my practice, but it became a part as I realized that the aneurysm business was drying up. And also you can see the importance and also the growth of the cavernoma story, as I just mentioned. So these are the clinical imperatives: embrace the hybrid model, maintain robust fellowships, maximize your volumes by subspecializing within your center. We should, as a specialty, limit the numbers of specialists. We should look for ways of strengthening the old-fashioned referral network through physicians. And we should see if we can't develop a method of metrics that measure performance as an aneurysm surgery. We should also partner with our health system to generate these centers of excellence, and we should try to re-centralize the really complicated care that demands the expertise. And lastly, maximize other volumes: skull-based tumor surgery and complex cranial surgery. Next, I want to talk about research. So I've recently, just a few months ago, published my 1000th paper on PubMed, but it's bittersweet because I've come to the conclusion that a lot of the neurosurgical community just doesn't spend time reading papers. They are very saturated or over flooded with this paper source, and so it's not what it used to be. I've really enjoyed the science around decision making, and this is just an example of how the supplementary grading system here, or the Lawton-Young grading system, augments or supplements the Spetzler-Martin grading system to get people, clinicians who are in the position of choosing patients to make the right decisions. I enjoy this. I've done it with brainstem cavernous malformations with this grading scale, and this is just a little tongue-in-cheek humor about the numbers of grading systems that I've put out there. But that's one area. The other area is taxonomy. I enjoy looking at the spectrum of pathology within vascular surgery, and I see a lot of it. So having a taxonomy that allows you to recognize these problems and simplify our understanding to bring some sort of understanding or insight into our consciousness. This is a fun exercise, and so taxonomy for dural fistulas has been valuable. I've worked on this taxonomy for brainstem cavernous malformations, worked on taxonomy for bypasses when we introduced the type 4 different types of bypasses over here. And it's important. It's like when you're on safari and you see all of these unusual animals from your Jeep. You can simply just marvel at the variation, or you can endeavor to really understand the differences and study the different species that you're seeing. And I think it requires this field guide to really get a handle on that. And that's where taxonomy becomes so valuable. These are the taxonomies that permeate each of my 7 books, the aneurysm, AVM, bypass, and cavernoma book. And each one of them has its own taxonomy and also metaphor. When it comes to the basic research, this is sort of the arc of my research on AVMs. I started over here with this very crude artery to vein anastomosis that was surgically created that led to the formation of dural AV fistulas. We then studied the effects of radiation with my first NIH grant, the KO8. And currently we have a wonderful model in a transgenic mouse where we can delete ALK1 or we can upregulate KRAS in ways that generate true AVMs in brain tissue that look just like what you see in patients. So this is the arc of research, and it's remarkable to see how far we've come in the 30 or so years that this arc has unfolded. But I have to say that the state of the art is pretty disappointing. There have been very few inroads in stroke or subarachnoid hemorrhage. There's declining funding. There's loss of resident research time due to the enfolded endovascular training. And a lot of residents these days just aren't interested. They're interested in other things like device development. So even though we have these wonderful models like this Hashimoto model in our Aneurysm Center for Aneurysms, or this AVM model, which I just showed you from Dr. O. This is the ALK1 deletion model, but also there's the KRAS model as well. We have these wonderful systems now for studying AVMs. Here's the KRAS upregulation, where we can, in general, turn an AVM on and off. We can form it here. We can turn off that particular gene and watch the AVM regress. And then we can turn the gene back on and reform it. So there's remarkable things that we're learning about AVMs even, and yet the interest is not there. I'm going to skip this slide and just go on to say that, you know, the times are changing. We've gone from this type of grading scale where we use a very crude, very simplified way to select patients to one where I think, you know, with AI, we're going to be able to feed in incredible amounts of data from the electronic medical record about demographics and about smoking histories and about hemodynamic flow and about wall tissue thickness and so forth. And ultimately, the AI is going to give us the selection variables rather than this very crude system of scoring. But again, I think the interest on the part of the residents is on devices, particularly in the endovascular space. And it's fun. These are just surgical instruments that I've worked on. I feel like the surgical toolbox needs to be upgraded. And so we've spent a lot of time with industry making these disposable scissors or these micro grasping forceps and these arteriotomy scissors for bypass arteriotomy and these bipolars that use a whole new metal material, a copper alloy, rather than aluminum to advance the thermal performances of these. These are all a modernization of the neurosurgical toolkit, which have come from our efforts with industry. And here's just another listing of those things. And so the innovation is there. It's fun. It's commercializable. So this is an area, if you're interested in research, but not necessarily wanting to do basic research or basic science, this could be another outward expression of your curiosity and drive. So here's the research imperatives: encourage basic science where you can, develop neurosurgeon scientists, apply AI and neuroanalytics to increase precision of our decision-making, encourage this device-related research and clinical trials, encourage innovation and entrepreneurship as an alternative to the basic science, and look for these, what I call innovation blue zones, where you can bring your new ideas into the clinical arena. Lastly, education. This slide kind of summarizes the state of things now. Even though that slide I showed you demonstrates some decline in the case volume, I think the interest is pretty steady. And we're having more and more residents flooding into neurosurgery because our residencies are slowly creeping up in their complement. So we're having to teach and learn the same amounts of things and case skills with less cases and also more complexity. And so it's a very difficult dynamic, and we don't have good training substitutes like the airline pilots have with simulators. We have cadavers, we have bypass simulation, but we don't have good training simulators for things like just open micro neurosurgical technique. So we've got to educate, and you know, I think for educators like myself, it's kind of like being a rock star. You know, you have to not just do one album, you have to constantly generate the next album and the next album and the next album. Otherwise, your audience loses interest in you and you become irrelevant. And so that's why I've continued to try and write the books. This one here over on the right is the latest. It's now released. It's published. I have a copy, the very first copy in existence right here on my desk. I don't know if you can see that, but there it is. So it's out there in the world. It's sold by Tima. You can order the book next month and get your own copy. But this is really what education is all about. You know, writing books, getting your thoughts and concepts on paper so that your ideas become known. This was a quote from one of my observers who just kind of highlights the importance of the effort. You know, when she was doing her first aneurysm or bypass or AVM, she turned to these books for her tips, and they really helped. It says, "Your teaching continues to enrich my training and professional development." I wanted to say thank you. So I think it's also fun to imagine new ways of teaching. This is our Eller telepresence room in Barrow in Phoenix. And you can see how making a small teaching environment, having a telestrator, bringing live surgical videos or surgical videos from the day's cases is a great way to just do new things that teach residents how to be better. And we're doing that. This is Rokuya Tanakawa showing one of his videos in that format. We've got a giant screen on the wall. You can see things that are blown up in their magnification 20, 40 times. And so you really have this immersive experience where you can really hear from the masters and learn to be a better surgeon. We have people that come from around the world for our observership, from all countries, all continents, all walks of life. And, you know, it's a really great way to teach, to show people as we do these cases, how we do them with all the intricate detail right there in front of them. We've created what I call a virtual residency, where by just following me or Barrow on Instagram or X or Facebook, you can essentially put yourself into our residency, and you can see the videos, you can experience the cases, and those videos transcend time, travel, rotations, expense. They're ways to connect. They're ways to see things that you may not be seeing within your own four walls. And so it's your opportunity to connect, and it's our opportunity as well to educate beyond the people that we select for our training program. Simulators are great, and we've made these models that help students learn things like making a craniotomy, knowing where to make the cuts, tying that to the skull anatomy or the views that you get intraoperatively. But they're crude at best. There are interesting ideas that we're exploring here. This is a hand tracking device that looks at master surgeons, like this is Dr. Tanakawa, and we can track him as he sews a bypass and try and unravel his maneuvers, the things that he's doing that make his technique different or better or expert. And we can also study the novice and help them see what they're doing wrong or what they need to improve. So these are tools that we're working on. They give us data that doesn't exist. So this is new data, new insights, and I think as we evolve the science of this, we'll have new ways of actually getting to these simulators and these kind of AI-driven coaching tools. We may even get to a state where we can inject some of this teaching insight into the oculars of the microscope, so that, like here, you see these visual cues. This is a resident operating. He's being given cues by the computer, by AI, to make this next move. And these can be ways of surgical navigation that don't exist today. This is a slide showing what we do in our global neurosurgical efforts. This is Mission Brain. Here you see Dr. Q, Dr. Quinones. This is me here. We're in Guadalajara, Mexico. And by traveling to low and middle income countries, we're able to teach those who are on the front line, who maybe are seeing more aneurysms than we are, who need our expertise. And also, it gives us opportunity for our residents to go and have additional cases to compensate for those declining volumes, which I showed you earlier. So this is us in Kenya and Tanzania. Our Tanzania place here is in Kilimanjaro, where we have residents and we have Barrow residents, and we also have faculty. And this gives us opportunities to both teach and to help develop our own learning through their experiences and sharing our experiences. This is in Dar es Salaam. This is just to show that there's a real appetite for learning and exchange. And so I think this global neurosurgical effort that's led by me and Dr. Eligala and Carrie Vaughn, it's a really important aspect of the global mission. So the educational imperatives are to stimulate interest in cerebrovascular surgery, strengthen the fellowships, find novel teaching modalities, find virtual or create this virtual residency through media and videos, continue to work on simulators and educational technology, and to promote these global neurosurgical programs like the Barrow Global and Mission Brain programs. So I'm going to stop there. My final thoughts. This is a crown jewel of neurosurgery. It deserves to be preserved. I think that it's being threatened and endangered by market forces, but we need to work hard to save it. I think for those who are interested in doing this, follow your passion. Keep trying to make yourself into that triple threat where you have clinical excellence, you have some basic research, and you strive to be an educator both locally and globally. Thanks.
Okay, Abdel? Go ahead,
Okay,
Abdel.
Dr. Ziad Al-Kamar, speak.
Yeah. First of all, thank you so much for that. I think I speak for us all when I say that we're very curious to see what the next decade or two have to offer to us as the future's neurosurgeons. I'm opening the floor to questions right now, but to kick off the discussion, I had two questions of my own. I had a theoretical question, then a practical question. The theoretical question that I had was out of personal interest. So your 7 series is like essentially like an organization of these like complexities down into a repeatable archetype, like this pattern that can be repeated over and over. What I was curious about is, as someone who likes teaching and explaining things to people, is the 7 series your way? Was it primarily pedagogical? Like, was it made for training purposes and to sort of narrow down these complex topics into a language that we can understand as less experienced people? Or is it like evidence of the brain's intrinsic, like, geometrical patterns? Like, do you think there are patterns that are waiting to be codified and discovered? Or is it us imposing like these technical, like artificial techniques onto the brain's anatomy, if that makes sense?
Well, I think when you're doing something that's creative and you're introducing that into the world, you don't always know how it's going to land. And so if it's a pedagogic tool that helps people, med students, residents learn how to be better surgeons, then that's one way that it lands. And that's frankly what it was intended to be and to do. But if it can also serve as some sort of a way to chart the territory of the brain, the architecture of the brain, I think that's how you meant that. Then I think there's value there too. I think what we're building here is an archive of videos that's both educational and also potentially applicable as a training tool. It's almost like when you gather data for a self-driving car, you're getting a library of trips down different parts of the streets or highways, a particular region. And when you assemble those, you're creating a digital twin of the reality of the roadways. And I think the same could be said of what we're creating here. These could ultimately become something bigger than just an educational tool.
Okay. My second question was a lot more practical than that. I have several contacts who I know here. I'm a 5th-year medical student in Turkey, and I've seen several people visit Barrow for observerships. I wanted to ask how favorably Barrow looks at elective programs or away rotations for either like national or, in our case, international medical students, and whether we were at all eligible to apply for something like that.
Well, the observer program is exactly meant for international students. It's very difficult for IMGs to match within the American match. So, it would close the door to so much of the world if we just limited our exposure at Barrow to our residents. So the Observer program is meant for all the others who have interest and who qualify in one way or another to come and learn. And as I showed you in that one slide, we've had over 600 over just the last 15 or so years. It's very robust. We have anywhere from 5 to 15 observers at Barrow at any one time, and they come from all over the world. So, you know, we are very liberal and open in who we accept. We like them to be people who are on their way to being neurosurgeons, whether they're medical students, residents, or young graduated neurosurgeons. But we don't want to open the doors to people who are going to go into pediatrics. You know, I mean, there's not a relevance. But if we have genuine interest in, if we see genuine interest on the part of the observer who has ambitions to become a neurosurgeon, then we're all open.
Okay, I see. Alrighty, well, let me not take up all the question time. If anyone else from the panelists or from the audience has any questions, please either put in the Q&A section or raise your hand. We got a question in the Q&A section. So someone gave their greetings and they asked, they said, excellent presentation. And then they asked, does Afghanistan do like neurosurgeons from Afghanistan benefit from the program? And this was asked by Dr. Pirzad. That's all they said.
Yeah, absolutely. We've had observers from virtually every country, and certainly Afghanistan is part of that. So, you know, we don't discriminate against any country. It's there are some bigger hurdles with some countries because of visas and travel restrictions or bans, but that has nothing to do with Barrow. That just has to do with the U.S. government.
Well, I have a question, if you permit me, Professor.
Go ahead.
Well,
Go
I
ahead.
have a clinical question about aneurysm. So now, if we suppose that the aneurysm just ruptured, and I just heard that, you know, if you don't collaborate in the first 72 hours, you cannot do it till 21st day after rupture. So what do you think about this information? And what will happen if someone just collaborate during the day from, I mean, day 4 to 20 day?
Yeah, well, I think the first comment I would make is that you can't have this dogma that doesn't have meaning. You know, if there is no rule that says you can't fix an aneurysm after 72 hours, that you have to wait till 21 days. You know, if a ruptured aneurysm shows up at 73 hours in my hospital, and I feel the patient needs to be secured, the aneurysm needs to be secured, we're going to the OR. The only reason not to operate is that if you operate on a patient who's in vasospasm, florid vasospasm, for example, the vessels are a little bit sensitive to the touch, and hemodynamically the patients are very unstable. So that's the concept behind waiting, but you also have the problem of re-rupture, and that, I think, in my mind, trumps everything. So we operate, you know, and sometimes if the patient is in florid spasm and you need to secure the aneurysm, you can coil it. So you have to look beyond the rules, the dogma, and put the patient's life in perspective and use common sense as a clinician.
Well, is there a way to deal with vasospasm? I mean, if it happened?
Sure, there are many ways to deal with it. You know, if you've got an unsecured aneurysm and patient's in spasm, then we would coil the aneurysm and immediately treat the vasospasm, either with an angioplasty or an intra-arterial vasodilator.
Okay.
Okay, Dr. Lawton, I have one question.
Go ahead.
Uh, Okay. Money, an aspiring neurosurgeon around the world had dream of learning from like the Neurological Institute. What 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 qualities should young medical students develop to become a strong candidate for future research fellowship or observership?
Yeah, well, I think if you're interested in becoming a neurosurgeon and you're asking, what should you do to become the best neurosurgeon you can be, I think it really boils down to just throwing yourself into the specialty and immersing yourself, following your passion, developing your passion. These are great cases. These are challenging patients to manage. The anatomy is exquisite. There's just so much about it that's going to propel you forward. And the more you get that energy from the specialty, I think the more you'll find that success is inevitable. When I was a medical student jumping in, there was so much that I was curious about, that I enjoyed learning. It was fun to study the anatomy, fun to figure out all the circuitry in the brain. I enjoyed that, and that helped me become a better resident and a better neurosurgeon ultimately. So I would just say follow your passions and keep working hard at those things.
Okay,
Okay.
Kamara, I think Harishi's next. Go ahead, Harishi.
Yeah,
Go ahead.
had a question. I think he was raised his hand.
Thank you so much, Dr. Lawton. It was such an insightful talk. As you mentioned in your presentation about the intersection of entrepreneurship and neurosurgery, as someone who was interested in that area, like what advice would you like to give to early neurosurgeons with the advancements taking place in AI and technology who are hoping to take up that area?
I would just say go for it. I would, when I was in my early years, that was never told to me. We were always told to go do science, get a lab, go get NIH funding, and be a surgeon scientist. Nobody said go be an entrepreneur and do the science that advances your device or your company. And I think that's changed. I think that is an equally solid justifier of science, which is to develop a device and test it in an animal, develop a clinical trial, prove that it has efficacy, and on and on and on. And that's science in and of itself, but with a different flavor. And like I said in the talk, I think there are many who see that kind of a road forward as much more rewarding or aligned with what they want out of life than just pursuing science for knowledge's sake.
Thank you.
Alrighty, I think Marwan was up next.
Yeah, thank you, Doctor, for this amazing presentation. I just had a question or a proposal, if you think about it. Like you mentioned a lot about the decline of open cerebrovascular surgeries, and that what Barrow did as to like go abroad into low and middle income countries to teach neurosurgeons more because maybe they see aneurysms more. So is there like, it's like a question or proposal, is there like a program for patients with complex aneurysms from low or middle income countries? Maybe they won't get treated in other countries, but maybe because in Barrow Clinic or in Barrow Institute, there is a need for open cerebrovascular surgeries, that a program for them to facilitate their treatment in that institute. So maybe it's a win-win both ways, to get more cases and to get treated.
Yeah, well, it's a real dilemma because you're right. There are a lot of patients in low-income countries that just simply won't be treated because they don't have the expertise locally to treat them, or it's too expensive, and so they won't get treated. Well, the answer is, you could send patients over to Barrow and we could treat them and provide that service, or we could go over, as we have on many occasions, on missions and try and train people locally, and those cases can then become part of the teaching process. We've struggled with that. I think global neurosurgery or global surgery generally has struggled with that because sometimes these missions are short-lived and the follow-on care isn't there, and there have been arguments that you're doing a disservice by just coming and going like that. So it's a complicated problem, but our approach has been to try and educate the local surgeons as best we can, try and keep the therapies, the surgeries local, and allow this problem to be solved in a local way. Moving patients out is too expensive. I don't think that's the answer. Moving surgeons in temporarily is probably not the answer, but developing partnerships where technology helps to have a constant connection, like what we're doing in Kilimanjaro through our faculty rotations and our visits and our tech. That can help really elevate sites. And if this works in Kilimanjaro, then it may work in Dar es Salaam and the next place and the next place. And then we can stitch together this true global network where we're all learning from each other and we're all helping each other, and yet people aren't having to leave their local environment.
Yeah, great. Thank you.
All right, we'll take one more question from the Q&A section, then we'll move on to the other panelists. Someone asked a very broad question about the research, like the neurosurgery research fellowship at Barrow, whether one exists and whether it would, like who it's open to, but it's a very general question. If you have any insight to provide on that.
So we have 4 research fellowships that we fill every year, and they're usually filled by international medical grads. And part of that is because of our global perspective. Also, part of it's because what I mentioned to you, a lot of American medical students aren't as interested. They wanted to go straight onto the match. And so we do fill them with IMGs. And if you're interested, you should go to the Barrow Neuro website. And Dr. Pruill is the one who leads that. It's primarily based in our skull-based lab, where we do cadaveric dissection and do our science through those kinds of studies. So they're good opportunities for budding neurosurgeons to get their hands on microscopes and instruments and cadavers.
Alrighty. So we'll take a question from Aisha.
Thank you, Dr. Lawton, for such an amazing lecture and sharing your expertise. I had a question regarding research in basic science in cerebrovascular neurosurgery. So if we want to get involved in research with basic science, do we do it like after our med school or after our residency? What is like better option?
Well, I think the answer is you get involved every step of the way. I did basic research as a medical student. I did a year of research as a resident, and I had a lab. I've always had a lab as a faculty member. So I think the answer is, find out what question you're interested in answering or what problem you want to solve, and just start. Because these questions, you get to an answer, but then they lead to the next question, and there's never an end. So you just have to not compartmentalize it, but find something you want to solve and start.
Thank you.
All right, I'll take another question from Isha in a second, but about what you said, because that interests me as well. Are you more in favor of the idea of someone taking a few years after medical school and doing something like a research fellowship, or do you think it's smarter to try and juggle both residency and research together, like integrate them into one another?
Well, that's a tough question. I think it's if you're an international medical grad and you're trying to get into an American residency spot, it's going to be very difficult to do without having taken time between med school and match to do that. So if that's your situation, then I think, that's what you do. If you're an American medical student and, you've done well in school and you're poised to match well, then you don't need to take the time unless you want to. But I would say that it used to be that very few people took the time and slowed down their progression. But these days, more and more are doing it. And those that do, they end up writing a dozen papers. They end up enhancing their application so that when they do enter the match, they tend to get higher choices in the match. So I think there's arguments to be made for that. And plus, again, if the goal is the goal shouldn't be just to get to the next rung of the ladder. The goal of the
Yeah.
research should to solve a problem that needs to be solved. And if that really, if you want to do that and you can begin that process early and kind of get your momentum, then I think there's some benefits to that.
Okay. Isha, we'll get a question from you.
Yeah, thank you, Dr. Zayed. Dr. Lawton, it's so nice to meet you online and to have the opportunity to hear you speak. I recently graduated medical school and I'm right now doing an observership in neurosurgery. I begin a hands-on attachment next month, and I've had the opportunity to see a lot of cerebrovascular cases as well. And given your experience, and now I'm assuming it's about thousands of AVM or aneurysms, I was wondering if you still encounter any that surprise you. Maybe they behave unexpectedly from the plan that you had made, and intraoperatively is when you decide how to modify it, because cerebrovascular cases can be unforgiving. And I'm sure, even for someone as experienced as you, how do you approach that? And subsequently, how do you teach the other doctors in your team on how to handle something so high stakes?
Yeah, well, as long as I've been doing it and as many as I've done, there's always the surprise. You never
Yeah.
outgrow the surprise, unexpected curveball in a case. So yes, there's always going to be that. And to be honest, that's what makes it continually interesting. If I've seen everything and done everything already, and there's nothing new under the sun, then I would probably start to get bored and distracted. So I'm thankful that aneurysms still rupture on me, and then I have to do a bypass that's super challenging and makes me really sweat it out. And you have to sort of relish the negative or cherish the negative. And then as far as teaching that, well, we spend a lot of time talking about strategy and things that go right and go wrong in a case. So, when a resident ruptures an aneurysm and they have to deal with that, we'll look at the tape, the video, and I can tell exactly what they're doing right, what they did wrong, how they need to improve. So part of that learning is to sort of, just as athletes do, break down the moves and look at the performance and try and get them to control their emotions and have a clear head about how to make the next series of steps. And it's just simple training.
Right. Yeah. So your point is to strategize and then learn from it as well.
Yeah, you kind of intellectualize or conceptualize things. We discuss cases before we go into the operating room, and we will discuss, what happens if it ruptures at this moment? What's your next move? What's the next move after that? And so you get younger residents to begin the process of training their minds to think through the scenarios, the worst case scenarios, and to have these contingency plans. And I think that's training. That's just teaching residents how to prepare their minds so that when they're in the seat and they're encountering a problem, they know exactly how to deal with it.
Right. Thank you so much.
You're welcome.
All righty. We'll get a question from Tasmia.
Hello, Professor. Thank you so much for your time, first of all. And my question is related to your presentation. You mentioned a concept about blue zones in the vascular surgery innovation. Would you like to elaborate on it for us, please?
Yeah, so yeah, the blue zones are kind of what I would call areas that require some thought and some research that haven't really been explored yet. So like, it's one thing to go into open vascular and go study stroke or subarachnoid hemorrhage, but it's another thing to go study the science of simulation and how we're going to build a better simulator that trains for just what we were talking about, you know, the possibility of an interop rupture that you've never experienced before. That's a blue zone. That's something that, you know, doesn't really exist right now, but clearly is a problem. Clearly there's a need. And by going into that blue zone with an area of expertise, whether it's like an engineering background or a computer science background or a machine learning interest, that's a blue zone, and bringing a unique set of skills into that blue zone.
Thank you so much.
Shahid? Go ahead,
I'm sorry.
Shahid. Go ahead, Shahid.
Oh, okay.
Thank you so much, Professor, for the amazing lecture. I wanted to ask, as a student aiming to specialize in neurosurgery, I would love to know, looking back on your career, what one decision or insight from a particularly challenging case has shaped how you approach complex surgeries today? And what advice would you give trainees for that experience?
Well, boy, I don't know that there's one case that's had such a profound impact. I mean, you know, I've done, as I told you, 12,000 surgeries, and I think that there are definitely some memorable cases and some real standouts. But you know, I think it's more the feelings that come from having done all of those cases. You know, each one is a step on a long journey, and every one is important. You know, from that simple PCOM or running into a wall on a basilar apex aneurysm clipping to a failed bypass. I mean, there's so many things that that affect you. It's hard to really just point to one thing. I guess what I would say is just we are this canvas of all the different things, all the different points of paint that get applied to the canvas. And yeah, there might be one bright spot here or there, but it's the collection of all of that that matters.
Thank you.
All right. I think there's one last question from Rishikesh.
Yes. Dr. Lawton, based on experiences and forward sightseeing, what one or two problems do you think which current global neurosurgery is facing, which if solved or cracked could revolutionize the field for the good?
Well, I think the biggest problem is just economics and manpower. You know, the cost of doing what I do and what I've shown you is my practice is just too high to practice in most places. Patients can't afford it, and economies can't pay for that. So I think one big challenge is to find ways to bring the cost way down. And then the other is a manpower thing. There are 5 million surgeries, neurosurgeries every year that are not done because we don't have the manpower. And it's partly a poor distribution of manpower. You know, there's a ratio of 1 neurosurgeon to every 65,000 in America, 65,000 patients. In Tanzania, it's 1 neurosurgeon to 15 million. So, you know, I think part of the problem is to just find ways to redistribute the workforce or find ways to elevate the the impact in low income countries where that one neurosurgeon that's covering 1 million patients can do more.
And what are your views about like brain-computer interface, the concept of Neuralink and all?
Well, we did the first Neuralink patient at Barrow, and we've done 7 of the 10 that have been done in America. Elon Musk came to Barrow and was part of our initial surgery, and I'm completely convinced that this is a device that does incredible good and has a really bright future for patients who are paralyzed, patients with ALS. And I think the potential for other disorders, not only traditional neurosurgical problems, but also psychiatric illness, is huge. So I'm a 110% believer in this. I'm actively working with them and working with other BCI companies to advance the field because I'm super excited.
Thank you so much.
All right. Well, I think that wraps up all the questions that we have. I'd like to say thank you so much again for taking the time to speak to us. And hopefully you'll be seeing a bunch of us over in the US at some point. And yeah, thank you all for joining. Thank you, Dr. Lawton, again for being here. And yeah, hope to see you all next time.
Great. Thanks for having me.
Bye-bye.
Thanks, Michael. Back to the bike.
Thanks.
Thank you so much, Professor.
Thanks.